It gives me great pleasure, though, to introduce Nikolaus Marx, who's Professor of Medicine and Cardiology, as well as Head of Department of Internal Medicine at the University Hospital in Aachen, Germany. And Nico is very well known and very well experienced in this area, and will address the topic of GLP-1 analogues and the DPP4 inhibitors, and we'll discuss the outcome of benefit for some, but not for others, as was hinted at earlier this morning. Nico?
Yeah, thanks, Derek, for the kind introduction, for the invitation. It's a great honor to be here. You gave me a very difficult question, and to manage expectation, I'd like to cite Dan Drucker. I think Dan is still around. He was saying that he doesn't know the difference here. So if he doesn't know, how could I know? Just to manage expectations, okay? So this is my conflict of interest slide. I collaborate with various companies, but don't take any personal honoraria. I think I don't have to set the stage here. I'm supposed to talk about GLP-1 analogues and DPP4 inhibitors, and to do so, what I'm going to do in the next 25 minutes or so is to quickly review with you some of the results of the recent CVOTs with DPP4 inhibitors and GLP-1 analogues, and then discuss with you the potential mechanisms that explains some of the differences here. Let's start with the DPP4 inhibitors. I'm sure you're all familiar with that, so we can do that fast. We had two trials, Examine, Savor, and TICOS, comparing as a safety non-inferiority design trial allogliptin, saxagliptin, or sitagliptin versus placebo, and you know the results. There was no signal of harm here, and the conclusion of these trials were that these trials demonstrated cardiovascular safety in high-risk patients with diabetes, but did not show any cardiovascular benefit. And we saw a safety signal that is especially of concern for cardiologists. That was in SAVOR, where saxagliptin led to an increase in hospitalization for heart failure, a signal that has not been found in TICOS with sitagliptin here. What can we expect in the DPP4 field? There are some more trials coming. Carmelina in a renal population next year, and another trial that Bernie mentioned already, that is Carolina. And Bernie, myself, and Julio Rosenstock are running these trials, so I'm in particular excited. And here we'll test the effect of linagliptin versus SU on cardiovascular endpoints. And I think this trial will address a question that is of clinical relevance and is different from the trials comparing a DPP4 inhibitor versus placebo. Let's look at the GLP-1 analogues. 4 trials have been published here: ELIXA, LEADER, SUSTAIN-6, and EXCEL. And the results here, ELIXA showed safety, EXCEL showed safety, and LEADER and SUSTAIN-6 showed a significant reduction of cardiovascular endpoints with a GLP-1 analog versus placebo. And I'd like to dive a little bit deeper for these two trials, starting with LEADER trial, 9,000 patients, randomizing liraglutide versus placebo, 3-point MACE follow-up, 3 years here, and you're aware of the data here. Significant effect in the liraglutide group versus placebo, with the separation of the curves here starting between year 1 and 2. Significant reduction of cardiovascular mortality and significant reduction of total mortality here with liraglutide. So if you look at the single endpoints here, they're all in the right direction here, significantly driven by a reduction in cardiovascular death, and seeing a trend towards a reduction in non-fatal MI and non-fatal stroke, as well as the separation of the curve after 1 or 2 years, resembling what we know from statin trials. I think it's fair to say that liraglutide reduces cardiovascular endpoint most likely through a reduction of atherosclerosis-related events. We'll come back to that in a few minutes. SUSTAIN-6, semaglutide once weekly versus placebo, short trial, 2.1 year, 3-point MACE here. Again, significant reduction of the 3-point MACE composite endpoint here in semaglutide-treated versus placebo-treated patients. And the significant effect here, and that was kind of surprisingly, was a significant reduction of non-fatal stroke. If we look at the other endpoints here, there was a trend towards a reduction of myocardial infarction, the significant effect of non-fatal stroke, and a significant reduction of revascularization here, again suggesting that semaglutide might reduce events through a reduction of arteriosclerosis-related events, but I left a question mark here because it would have been nice to see an effect on non-fatal myocardial infarction, for example. So let's look at mechanisms. Let's look at the comparison between DPP4 inhibitors and GLP-1 analogues first. In the GLP-1 group, 2 trials positive with respect to benefits, while DPP4 inhibitor trials were all neutral. And you've seen that slide already, a very nice paper published by Dan Drucker last year, looking at direct and indirect effects of GLP-1. So if we think that GLP-1 itself has an effect in this context here, this might explain the difference between DPP4 inhibitors and GLP-1 analogues, because GLP-1 levels achieved are different in patients. DPP4 inhibitors elevate endogenous GLP-1 to physiological levels, while GLP-1 analogues reach higher pharmacological levels, for example, with liraglutide, much higher than the physiological level. And these different levels may, to some extent, explain the differences between DPP4 inhibitors and GLP-1 analogues, but I realize this is a very, very cautious statement. Another aspect that needs to be taken into account, and Dan alluded to that, is the fact that DPP4 inhibitors are not 100% specific for GLP-1, but may also cleave other substrates, and so DPP4 inhibitors may influence the activity of numerous cardioactive substrates, thus having an effect beyond GLP-1, and it is undetermined whether these are favorable or unfavorable here. That's the best I can say for the comparison between the 2 classes of drugs. So let's look a little closer at the differences between the various GLP-1 analogues. And it's very difficult to compare clinical trials, and Bernie alluded to that before, but still, what I'd like to do is to have a look at the trial population and the event rate in these trials, whether the design of the trial or the population may explain the different findings. Let's look at the baseline characteristics here of the GLP-1 analogues. Age is about the same. Diabetes duration, long duration of diabetes, BMI, not much different. HbA1c, a little higher here, and the leader in Sustain 6. ELIXIR was a little different because this was a pure post-ACS population, different in the 3 other trials. Hypertension, prior insulin, about between 1/3 and 50%. So overall, there are differences, but still, I think it's fair to say that the differences in patient populations are unlikely to solely explain the different trial results here. Let's look at the event rate. And what I did in the next slide, I took the event rate in the placebo group and compared the event rate between the different trials here. Follow-up shorter in ELIXIR and Sustain 6 here. ELIXIR picked a 4-point MACE, including hospitalization for unstable angina, which is not a very strong endpoint, so we prefer the 3-point MACE. Total mortality, taking into account the duration of the trial, was shorter in Sustain 6, but otherwise not much difference. CV death, shorter, less CV death in Sustain 6 here. Heart failure hospitalization, not much of a difference. And there are differences in the event rate, but it's hard to say that this is a super high-risk population and this is a low-risk population. So I think differences in event rates between trials are present, but I'm not convinced that these differences are sufficient to explain the different results of these trials. So there has to be more to it here. Let's look at the effect on severe risk factors. And this is taken from a great review published by Michael Nauk and Dan Drucker in a recent issue of Circulation here. And they summarized the effects of various GLP-1 analogs on parameters like HbA1c, systolic blood pressure, body weight, and also included pulse rate. And I just highlighted for you the 3 GLP-1 analogs that had cardiovascular outcome trials already. And so you don't see much difference with respect to HbA1c lowering. There's a clear difference here with respect to systolic blood pressure in semaglutide-treated patients. This may be of interest if you think about reduction of stroke events, but this is a very careful statement here. Then not much difference on body weight. And in the contrary, as a cardiologist, I'm really concerned about drugs that increase heart rate here, but they do not much differ here. This is from phase 2 and 3 trials. If you look at, for example, LEADER and EXCEL, the trials that included long-acting or longer-acting GLP-1 analogs, and you take the 2-year time point, for example, here, and the 2-year time point is here. This is data taken from the trials. There's not much difference in the reduction of HbA1c, body weight, or blood pressure. So I think the differential effects on cardiovascular risk factors are, as to me, unlikely to solely explain the different trials. The trial results, they may have contributed, but I think it's not the one and only explanation here. So let's look at direct effects of GLP-1. Dan Drucker already showed some of the data that GLP-1 has some effects on the cardiovascular system here, and the clinical data from LEADER and SUSTAIN suggests that the reduction of events is related to reduction of arteriosclerosis-related events. So I'll show you some of the basic science data, for example, data published a couple of years ago from a Japanese group showing a reduction of atherosclerosis in ApoE-deficient mice here at 2 different doses of exenatide. We used a different approach to sort out the effects of GLP-1 in the murine system. We took ApoE-deficient mice and overexpressed GLP-1 737 in these mice and looked for atherosclerosis extension and plaque stability. And to make a long story short, we found that overexpression of GLP-1 significantly reduces macrophage content in these lesions, so reduction of inflammatory cells that are the kind of hallmark in arteriosclerotic lesion. And this translates into an increase in collagen in these lesions, suggesting that overexpression of GLP-1 stabilizes arteriosclerotic lesions. So from these animal data, GLP-1 might reduce lesion size and stabilize arteriosclerotic lesions, and effects that could very well come along with the reduction in arteriosclerosis-related events here. This has nicely been summarized again in this review by Dan Drucker. That's what I showed you here, but there are also effects on the heart that, for example, may also contribute to the reduction of CV death seen in the LEADER trial here. Still, if there are effects of GLP-1 in the cardiovascular system, why do we see a significant effect in LEADER and SUSTAIN 6, but not in the trial with lixisenatide and in the EXCEL trial? And this may has to do something with the structure of the GLP-1 analogs, because exenatide as well as lixisenatide are exendin 4-based GLP-1 receptor agonists with a 50% homology to the human GLP-1, while liraglutide and semaglutide are acetylated human GLP-1 receptor agonists with almost 100% or 95% homology. So the homology may be a point here. Another point may be the fact that the N-terminal end here of GLP-1 is conserved in liraglutide and semaglutide and is different in exenatide and lixisenatide. And this may play a role, but this is a hypothesis. We don't have data for that. All this is very elegantly summarized in this review that I already mentioned here. And Michael and Dan suggest that GLP-1 may have different effects that finally lead to cardioprotection, effects on the kidney, effect on the brain here, the effects on cardiovascular risk factors that I mentioned, and on the other hand, direct effects on the endothelium and the vessel wall and the heart. And all these together may translate into the reduction of cardiovascular events seen in LEADER and SUSTAIN 6 here. Still, if you read the paper, in the end, they say continued research is needed to better define the mechanisms leading to the benefits seen to date. And again, I can cite Dan, who said he doesn't know what it is. So the question is, where to go from there? What can we do here? And this whole story, having a clinical trial or 2 clinical trials with beneficial effects, but no mechanism, reminds to the SGLT2 story, because we've all seen the empiric outcome data, and we've all seen every good journal published an overview article here, and I have to say we, as well as Naveed, for example, contributed to that. And it's a little bit, it's an inverse correlation of the number of original articles concerning the mechanism and the overview articles. If you have no data, everybody can write an overview article. So that's what happened here. Still, we picked another approach to sort out the mechanism. And as an example, I show you what we did with empagliflozin here to work on the mechanism, because I think this is a concept that could also be of relevance for the GLP-1 agonists, analogues. So what we did, based on the EMPA-REG outcome data, we performed a prospective study in 25 patients with type 2 diabetes and cardiovascular disease. They perfectly fulfilled the criteria of the EMPA-REG outcome trial as lined out here. We drew blood at baseline and after 1 month and performed an untargeted serum metabolomics approach. So what you basically do, you take blood, give it to someone who can do metabolomics, and he's doing analysis here looking for different metabolites. And we've been able to identify more than 1,200 metabolites, 860 of them already identified, 400 unknown. And then you take this whole bunch of data and give it to a statistician, telling him that he should do a pathway analysis. So basically picking what he has and analyze whether this fits to any known pathway in the body here. And so we performed this pathway analysis. We found that 160 metabolites were altered by empagliflozin. And to make a long story short, we found that empagliflozin leads to an increased catabolism of branched-chain amino acids here, leucine, isoleucine, and valine. I'm sure you all remember that from medical school when we had all these big charts. In addition, we found that the catabolism of ketogenic amino acids is increased here. You're a diabetologist, most of you, you may say this is a glucagon effect. Okay, that's pretty fair to say. The question is, how does an increase in BCAA catabolism, does that have something to do with heart failure? And indeed it has, because it had recently been shown that a catabolic defect of branched-chain amino acids is a hallmark of heart failure here. So based on our data, we now generated the hypothesis, since BCAA catabolism is diminished in heart failure, empagliflozin could potentially restore these defects and together with the increase in ketone bodies provide an optimal energy source for the heart. So having seen these data, we now have a whole bunch of mice in which we analyze whether this has something to do, but our unbiased approach helped us to generate a novel hypothesis and open a new avenue, a new pathway to sort out the mechanism. I think that something similar could be of importance here with GLP-1 receptor agonists, and I think that unbiased approaches like mass spec or cluster analysis may generate novel hypotheses to explain the cardiovascular benefits of certain GLP-1 analogues, and my group is currently going down this line to hopefully generate novel hypotheses to find out why GLP-1 analogues have such a beneficial effect. So in summary, to address this difficult question, I think we can say that CVO2s with DPP4 inhibitors demonstrated cardiovascular safety in high-risk patients with diabetes. Multiple effects may have contributed to the different results of GLP-1 analogues in recent CVOTs, and I think unbiased approaches may generate novel hypotheses to explain the cardiovascular benefits of certain GLP-1 analogues. And with that, I'd like to close and mention the people who did the work in my lab, and thank you for your attention.